first and the foremost being genetic testing. Then, if you have a suspicion that this fetus might have had infection, so fetal infection assessment can be done. Other important things that can be evaluated via amniocentesis is to look for the hemolytic disease of the fetus, the Rh negative pregnancies, and the lung maturity. However, these things are now lower down because you have a separate thing to monitor these fetuses. You look for MCA moms, the PSVs, and for lung maturity, we have ultrasound and MRI based workups. They are coming up, so they point towards that. And decompression of fluid, the polyhydramnios, is the therapeutic component of amniocentesis. The above, they were all the diagnostic components, but the amniocentesis can be done therapeutically also. So what are the steps? How do we go about doing amniocentesis? Start with the needle selection and the track that you are going to follow. 20 to 22 gauge needle is good enough. Go transabdominally. Please monitor the needle end to end from the point it is entering the skin, the subacute plane, and the amniotic cavity. That should be under vision, and while removal also, everything should be under continuous ultrasound guidance. Remember, if you enter firmly, the firm entry will prevent any tenting of the amniotic membranes. So you have to enter very firmly. For placenta, if possible, avoid the cord insertion site. This is very important. So avoid it. If feasible, as we see in this image, this is the placenta. So if possible, the placenta is posterior. You have a very good window. Avoid placenta altogether, especially in patients who are Rh negative. And if you need a transplacental passage, for example, the placenta is anterior and there's no other window available, then transplacental passage can be taken, but they are associated with increased risk of a bloody tap and contamination. But the fetal loss, the risk of fetal loss between a transplacental and a non-transplacental does not make a lot of difference. Like they are both the same because it depends on the skill of the operator. But if possible, take the non-placental route and your entry has to be firm. So this will be demonstrated in a video also. Following that, now your needle under continuous monitor, we can see has entered into the amniotic cavity. Remove the stellate, aspirate 15 to 30 ml of the fluid, and this fluid collection can be done by you, the operator. Assistant can help you. So you are stabilizing the needle and the assistant will help you aspirate it. Or if you want to do it with the help solely, you want to do it, you can use a vacuum assisted device as well. Now, the thing that we were discussing, maternal cell contamination, that happens when there is blood in the tap that you have aspirated. So the risk increases with it. It is more frequently seen if you are going through the placenta and you're taking multiple passes. Okay, so if multiple passes are taken, again, risk of maternal cell contamination happens. Now, how do I minimize it? How do I minimize the maternal cell contamination? The first 2 ml of the sample you can discard. So what you can do it in this case, what procedure we follow at our institute is, first you insert the needle, the 22 gauge spinal needle you have entered, remove the stellate, take a 2 ml or 5 ml needle, take 2 ml, aspirate 2 ml and keep that needle separate. Now you can have 2 10 ml syringes and then you can store the sample in those 2 10 ml syringes. So that is how you can minimize the cell contamination. Now, when do you do amniocentesis? The timing of amniocentesis is usually at or beyond 15 completed period of gestation. So after 15 weeks POG, you can go for amniocentesis, and that is why it is known as mid-trimester diagnostic intervention. You can do it later also. Like earlier, it was done for the looking for the lung maturity. You can do it later also for lung maturity or at any point when you need a therapeutic amnio reduction or to look for infection. But from the point of view of diagnostics, 15 weeks is the cutoff. Okay, this is from the ECO guidelines. So 15 week is the cutoff. Now, there have to be some contraindication. You cannot go in doing amniocentesis in all the patients, even if indicated. Now, what are those contraindications? First is active maternal infection. Say these HIV and hepatitis, we will discuss what are the things that can be done and how to go about it. So this is not an absolute contraindication. Choriamnitis is something you don't want to, go in right into the infection, manage it, and then you can go plan the procedure. Placenta previa, if covering the needle path anteriorly and entirely, and you don't have any other window, so if there is no approach for this, again, it's a rare contraindication. Usually, radiologists get a path. So, if you're not getting a window, basically. And if it's a Rh negative pregnancy and severe maternal alloimmunization is there with a very high risk of fetal demise, then you don't intervene. If a patient that has come to you for amniocentesis is experiencing unexplained vaginal bleeding or is under some complications like threatened abortions, why would you intervene? So these are the relative contraindications. Now, there are laboratory aspects of amniocentesis. So once you're done with the procedure, patients will expect you to, will ask you when will the report come or what are the timelines and what information will I get from this procedure. So you should know that there are two things that bother the reporting. First thing is culture failure. So culture failure happens in 0.1% of procedures. It is basically if you are having a sample which is blood stained or the gestational age is quite late. So at these times, the culture fails and hence no, the evaluation is not done. And once you are having a contaminated sample, again, the risk of amniotic cell mosaicism increases. It happens in around 0.25% of the procedures. So this is again and looks like it can, hamper the progress of the pregnancy or your clinical decision making. Then fetal blood sampling or a repeat amniocentesis. Both can be done, but the fetal blood sampling will help you rule out true fetal mosaicism. Okay. So basically, these are relative contraindications. So if patient is having an infection or you are not getting a window or is patient is experiencing a problem like vaginal bleeding, is leaking or has a lot of pain, threatened abortion, then we would not do the investigation.